Now I'd like to introduce our speaker, Dr. Jenna Wareheim. Dr. Wareheim is a graduate of the Edward Via College of Osteopathic Medicine in Blacksburg, Virginia. She completed her residency in obstetrics and gynecology at Tri-Health in Cincinnati and is a board-certified OBGYN. She moved to Louisville in 2020 and completed her fellowship in urogynecology, female pelvic medicine, and reconstructive surgery, at the University of Louisville. Thank you for joining us today, Dr. Wareheim.
Thank you, and thank you for that introduction. I am going to share my screen here. Okay. And is that showing up okay?
Yes.
Perfect. Okay. Okay, so today we're going to talk about, or I'm going to talk about the pelvic floor disorders and the benefits of pelvic floor physical therapy. As Dr. Jennings said, I did my fellowship in urogynecology at the University of Louisville, and was lucky enough to work really closely with some pelvic floor physical therapists in the area and learned and gained a good appreciation for what it is that they do. And all the amazing things that they can help our patients with. So I have nothing to disclose. Objectives for today, I'm going to review some common pelvic floor disorders and talk about what pelvic floor physical therapy actually is. Identify pelvic floor disorders that can be helped by pelvic floor physical therapy, and talk about some of the data that's behind pelvic floor physical therapy. As our population ages, pelvic floor disorders are becoming more prevalent and increasingly important health and social issues. In the US, the largest segment of the population growth-wise is women above 60 years old. And approximately 63 million women will be 45 years or older by 2030. And it's estimated that 33% of the population will be postmenopausal by 2050. The prevalence of pelvic floor disorders increases as women age, reaching more than 50% by age 80. The media and patients are starting to become more aware of pelvic floor and all the disorders and dysfunctions that can go along with it. And with that, focuses are also shifted to non-surgical options such as pelvic floor physical therapy. The goal of physical therapy is to restore or enhance physical activity and health to achieve optimal functioning and improve quality of life. Treatment focuses on decreasing pain, improving strength, and counseling on safe body mechanics and movements. Physical therapy is a clinical doctoral program, and therapists are required to complete a graduate program, and then they also pass a state licensure exam. Women's health physical therapy is a subspecialty within the PT world. It involves additional training in the pelvic floor, lymphedema, pregnancy, and postpartum related issues. In the US, it's approximated that there's over 200,000 physical therapists, but only 3,000 of those that are licensed have specialized in women's health. There are multiple reasons for referral to a physical therapist, according to the American Physical Therapy Association. In regards to the pelvic floor, that includes pelvic floor pain, vulvodynia, dyspareunia, vaginismus, urinary or fecal incontinence, and pregnancy or postpartum related pain. During a pelvic floor physical therapy session, patients can expect to have an internal exam by the therapist. The therapist assesses different muscles within the pelvic floor and asks the patient to contract or relax those muscles. When they do that, they're assessing for duration of muscle contraction, accessory muscle use, and the potential for developing painful trigger points. Patients could try the exercises at home on their own before being referred, but in order to be successful, they would have to have good muscle coordination and the ability to contract and relax these muscles without guidance, which most patients are unable to do. It does require a little bit of commitment on the patient's part. Typically, the sessions are about 60 minutes. It's more common that they're about once a week, but they could be stretched out to every other week if the patient needs. And they typically go for about 8 to 12 sessions. It does require active participation and a motivated patient. And then they can expect, if there's going to be improvement, they can see gradual improvement. So it's not going to be a quick fix by any means. The improvement's normally seen by around the 4th week, but the therapist can also teach patients exercises to do at home beyond the 12-week session so that they're able to continue the therapy on their own. There are many urogyne-related diagnoses which can benefit from pelvic floor physical therapy. First is urinary incontinence. The overall incidence of incontinence can vary, but is estimated to be around 34%. Many patients assume that surgery is the only way to see improvement, but multiple studies have shown that pelvic floor muscle exercises can be effective as a first-line treatment for stress, urge, and mixed incontinence. Stress urinary incontinence is the involuntary loss of urine with effort or physical exertion, such as exercise, lifting something heavy, laughing, coughing, or sneezing. In most cases, patients are unable to contract muscles with enough power or endurance to stay continent during these periods of increased intra-abdominal pressure, and as a result of that, they end up leaking. Treatment options for stress urinary incontinence involve behavioral and lifestyle modifications, pelvic floor physical therapy, and incontinence pessary and surgery. Studies have shown that pelvic floor physical therapy has higher patient satisfaction at 3 months compared to an incontinence pessary. Physical therapy subjective cure rates are up to 53%, which compared to midurethral sling, which is a permanent mesh procedure, is only 85%. So half of patients will get the same benefit and improvement with physical therapy without requiring that surgical procedure. A large Cochrane review found patients undergoing pelvic floor physical therapy were 8 times more likely to report cure and 6 times more likely to report improvement and better quality of life compared to behavioral modifications. Overactive bladder is urinary urgency with or without incontinence in the absence of pathology. The urgency is often accompanied by nocturia, but doesn't have to be. Urge urinary incontinence is the loss of urine associated with urgency or a sudden need to void without deferring. Treatment options include, again, behavioral and lifestyle modifications, pelvic floor physical therapy, medications, intradetrusor Botox, and neuromodulation. So the only thing that can treat both the stress urinary incontinence and urge urinary incontinence is the behavioral modifications and pelvic floor physical therapy. In a systemic review of 15 studies, almost all patients involved had positive results with pelvic floor physical therapy. Among women aged 55 to their 90s, there was an 81% decrease in incontinence episodes after 8 weeks of biofeedback therapy. Another study showed that after a 12-week physical therapy course, patients experienced a 75% decrease in leakage episodes, and these results were continued in the long term up to a year. Interstitial cystitis is a condition where patients experience an unpleasant sensation perceived to be related to the bladder, associated with urinary tract symptoms, lasting for more than 6 weeks in the absence of infection or any other identifiable causes. The prevalence is unclear, as many women are not diagnosed until they see multiple providers, but estimates are approximately 1.2 million women within the United States. Treatment options include behavioral modifications, following an IC elimination diet, pelvic floor physical therapy, bladder installations, and cystoscopy with hydrodistension. Pelvic floor physical therapy is a second-line option, but patients should be instructed to avoid performing pelvic floor strengthening exercises such as Kegels on their own, as this can actually make their symptoms worse. A randomized controlled trial was done that compared myofascial physical therapy versus global therapeutic massage in IC patients, and it found greater improvements in pain, urgency, frequency, and sexual dysfunction among patients that received the myofascial physical therapy. Pelvic pain is a complex and often very frustrating diagnosis for patients. It requires an individualized approach to treatment and often a long time. Patients really need to understand that their pelvic pain likely didn't occur overnight, and it's not going to be a one quick, easy visit to get them feeling better. Pain that's strongly associated with myofascial origin or muscle tenderness and hypertonicity is more likely to benefit from physical therapy. And findings that could indicate this on exam would be pelvic floor muscle tenderness or a positive result on the Faber test. Pelvic floor physical therapy can help relieve pain and normalize muscle tone. And providers can consider using validated questionnaires like the vulvar pain assessment in order to gauge their response to treatment. Beyond muscle work, physical therapists have other techniques to treat pelvic pain, including ischemic compression, where the physical therapist holds firm pressure to a muscle or tissue until it relaxes, transverse friction massage, where the therapist uses a deep tissue technique at the site of the pain to break down any scar tissue and remodel it to become more pliable and functional. Dry needling, which involves the insertion of monofilament needles without the use of injectate to treat pain and dysfunction and neuromusculoskeletal conditions. The needles are inserted into, alongside, and around the nerves, muscles, or connective tissue with the purpose of decreasing pain and dysfunction. The procedure is similar to acupuncture, but the terminology, theoretical constructs, and philosophies do differ. There's also TENS units, which are therapeutic modalities that use low voltage electrical current for pain relief. It involves a small battery-powered unit with 2 electrodes that are placed on the patient's skin in the area of the pain or at a pressure point, and it creates a circuit of electrical impulses that travels along the nerve fibers. The units are popular and affordable, but they have low-quality evidence except when combined with dry needling and other types of treatments. Pelvic organ prolapse, this is what I tend to see the most in the office. It can occur in any compartment, meaning the anterior, posterior, apical compartments within the vagina, and can manifest as vaginal fullness, pressure, or a protruding mass. Most often, it's found on pelvic exam, and only about 3 to 8% of patients are symptomatic. Treatment options include expectant management, pelvic floor physical therapy for symptom management, a pessary, or surgery. Decreased pelvic floor muscle strength is associated with increased risk of prolapse and need for reoperation. Pelvic floor physical therapy is useful in about 57% of women with mild prolapse based on the pelvic floor distress inventory questionnaire. So that's one of the validated questionnaires that we use when we first see patients in the office. One-on-one pelvic floor muscle training has been shown to be effective for improvement of prolapse symptoms with an average improvement of 9 points on the distress inventory questionnaire. Antepartum patients can also benefit from physical therapy. Many pelvic floor symptoms occur during pregnancy, including musculoskeletal pain and stress incontinence. Musculoskeletal pain can unfortunately become chronic and persist for 10 years or more in at least 10% of patients. Prevalence of stress incontinence reaches 60% in the antepartum period and up to 30% in the postpartum period. And these conditions can benefit from pelvic floor physical therapy techniques, including manual therapy, which includes mobilization, manipulation, soft tissue massage, taping, and bracing. Postpartum pelvic floor symptoms that experienced include urinary incontinence, fecal incontinence, overactive bladder, urinary retention, constipation, pain, dyspareunia, and prolapse. These can be secondary to pregnancy alone and can occur regardless of whether the patient undergoes a vaginal delivery. Often women will be attempting pelvic floor exercises on their own in the postpartum period, but there's been studies done which show that only 20% are performing these exercises correctly. And this number is improved to 74% with just verbal instruction from a trained physical therapist. The physical therapist can also work with patients on proper body mechanics. So as you can see here, and I'm sure anyone that's had a newborn knows, it's easy to lose these good body positioning and ergonomic positions. So it really puts you at risk for long-term concerns like back pain if you're standing incorrectly or sitting incorrectly while taking care of a newborn. Constipation is one of the top 5 most common diagnoses for GI disorders. Outlet type constipation is known to be more prevalent in women with prolapse or urinary incontinence. In a sample of 300 women, pelvic floor physical therapy improved symptoms of 71% of patients with dyssynergic defecation leading to constipation. And biofeedback therapy has been shown to be superior to placebo and oral laxatives. Fecal incontinence involves the involuntary passage of flatus or stool. Its prevalence ranges anywhere from 2 to 24%, but it's widely regarded as underreported. Treatment options include behavioral and dietary modifications, ensuring that patients are eating enough fiber-rich foods, an anti-diarrheal medication, pelvic floor physical therapy, and surgical management. Pelvic floor physical therapy has been shown to benefit fecal incontinence by improving a patient's squeeze pressure, urgency threshold, and maximum tolerable volume on anal manometry testing. Cost effectiveness, it overall looks promising, but all the studies do say that we need a little bit more assessment of this. None of the ones that I could locate or that I've read have included time and cost of patients being away for work. When comparing different treatments, the most cost-effective was during pregnancy in order to prevent urinary incontinence. But it was noted that pelvic floor physical therapy was not cost-effective when compared with a mid-urethral sling for stress incontinence. These are all of my references. I know, I'm sorry, that's a lot. And then I included just some examples of some of the questionnaires that we do to assess patient symptoms, such as the pelvic floor or PFDI 20, which is the long form. The global impression of improvement, which asks patients how they're feeling after treatment. The pelvic floor impact questionnaire short form, which has just 7 short questions and asks patients about their symptoms. And I can never pronounce this one, the score that gauges fecal incontinence. And that is all that I have. So a quick presentation today. And then thank you everyone for your time. And if anybody has any questions.
Thank you, Jenna. I really appreciate it. So I had a couple of questions that I wrote down during your presentation, and generally we'll get a few more to filter in in the Q&A box. But you cited 34% as the incidence for incontinence. Is that correct? Okay. Now is that all types? So the urge, the stress, all types?
Yes, correct.
And the reason that I ask is, as a primary care physician by training and 20 years of having done it, it sure seems like it's higher than 34%.
Mm-hmm.
So is it simply because I remember that all the people that had issues and we were trying to work on that with them, or has there been a change in the incidence over the last 20 or 30 years?
Well, there has been a change in the incidence just because that section of the population is growing. So that's going to increase it. But it's also, this looks at within the entire country and all all ages and demographics. So while it is increasing as the population age increases, this is just what's reported on physician visits.
Okay, so also the silent incontinence is not necessarily represented there. So
correct.
the incidence could potentially be 50% or more, but because we're not hearing about it.
Exactly. It's likely higher than that, but this is just what patients have actually reported.
Okay. Excuse me. And then on your interstitial cystitis information, clearly knowing your background and training, what you reported was women, but there is an incidence in men as well, correct?
It's extremely less common in men. Yes.
Yeah, and I think again, it's another one of those things that getting absolute numbers is very difficult, but it's like 5 or 10% of the total number of females that reported is the number of males that reported. It
Yes.
is extraordinarily low.
Yes, that's correct. Yeah.
And then I think from my perspective, having finished my training in 1999, we certainly did not have well-trained physical therapists for pelvic floor issues at that time. And it's probably been between 10 and 15 years that it's really come into my consciousness. So is this a relatively new brand of physical therapy and training where someone finally said, hey, this is really a muscular issue that physical therapy works for other muscular issues. Someone needs to branch out in this, or has it sort of been in the background somewhere and finally just gotten more popular because of its success?
I don't know the exact years and dates of everything, but I think that in terms of the Eurogyne data, this has really sort of come out in the last 15 years, if not less. That's when a lot of the studies that I cited had come from. So they're pretty recent. And because it's so specialized, it just hasn't gotten a lot of attention, I think, in the past. And we're realizing, as you said, these muscles in the pelvis can have a role in urinary symptoms and bowel symptoms. And I even get patients that come in and say, I think I have prolapse. I have all this pressure and it hurts and it's uncomfortable. And then they have no prolapse on exam. And it's really just their muscles of the pelvis are aggravated. And those are the patients that do extremely well with physical therapy. And even those same patients will say, oh, I'm having all this urgency and frequency, and I'm going to the bathroom in every hour. And just by doing physical therapy, that gets better as well. So I think that not only is our data a little bit newer and showing all these improvements, but the other hurdle is that it's a very specialized part of the physical therapy world, and not everybody has an interest in doing it. And somebody that hasn't done the additional training, if they necessarily haven't had the interest and the extra time for it, they can talk to patients about Kegels and the muscles, but if they're not doing that internal work with them, it's not going to be as beneficial. So it's finding the right physical therapist for the patient also.
And from my experience with it, again, going back 10 or 12 years ago, the one hurdle that I had to get over with my patients, and I made sure that I got over it from the front end instead of trying to deal with issues in the back end, was that I don't think my patients, until I thoroughly explained to them what was going to happen, realized how intimate the physical therapy sessions would be.
Yes.
And you expect to go to a physical therapist for your knee, but you don't necessarily expect to go to a physical therapist for your pelvic muscles. And thinking through that process of exactly how invasive that can and would be to them.
Yes.
Once that discussion takes place before they ever go, then their acceptance of this is going to help me get better from this, and it potentially will help me avoid a surgery. There's at least a 50-50 shot that I won't have to have surgery if I do this. You're a little more engaged in that process.
Yeah. So when I'm first meeting with patients, I give them all their options and I say, look, this is not required. And this is what it would entail. The pelvic floor physical therapist is someone that's done extra training and been specialized, and they do internal work, and it's this time commitment, but it can benefit all these symptoms you're having also, not just one thing. And when I present it like that, most of the time they would rather do that and start with it than jump to anything else.
So currently, I don't see any other questions here. Do you have any final thoughts or any other things about things for us to look for to try and either refer to Urogyne rather than trying to take care of it in the primary setting, or things that we ought to sort of be looking for that would be an indication that physical therapy might be the best place for us to start. And then if that fails, then refer to specialty care.
I would say that, so physical therapy, there's not much downside to it beyond the time commitment. It doesn't always lead to improvement that the patient would want, but I tell them it's worth trying if they don't want surgery or anything else. I think that it's important to look for someone that's specialized in the pelvic floor. So when I put in my order for the referral, I say in the description, pelvic floor PT, and that helps to kind of focus it a little bit more so that they don't end up with someone that hasn't done that training.
Sure.
Yeah. And then after that, it's just, I'm happy to see anyone and talk to them about their options. So anything refractory, probably, I would say is going to end up being a little bit tougher to treat.
I know probably even just 5 or 6 years ago, there was really only one center in Louisville that did a very good job with pelvic floor issues and physical therapy for it. Are there more available now? Because it's been, like I said, it's been several years since I have been in practice with a full panel of patients.
Yeah, there's quite a few. There is one at the Gray Street building at the downtown hospital. And then I know that there are some on Bardstown Road and the Hurstbourne area. I believe there's one out in LaGrange. So they're spread out, but there are quite a few around town. Yeah.
Because we always had to be cautious with which center we sent them to, because they may not have the fully trained people.
Yes. And there's some like patients that come from Elizabethtown. Unfortunately, there's none out there yet. But there are quite a few around the city. So.
Okay, I don't see any further questions, and I think I've run my gamut of questions. So I certainly appreciate your time, and I think that we are all better informed on what our options are when we're facing some of these pelvic floor issues.